Morning. All right, welcome everyone. I am Dr. Wally Siewert. I'm the Director of Civic Engagement for Focus St. Louis, and I am very much looking forward to leading this conversation this morning about the real mechanisms of pathways that are leading to disparate outcomes for African American populations, populations of color, all across the country, and specifically in St. Louis as a result of the global COVID-19 pandemic. Joining me this morning, we have an esteemed panel. I'm just going to give their titles. You can read their very impressive bios on the event page. I don't want to take everyone's precious Zoom time doing that. So joining us this morning is Dr. Fredrick Echols, the Director of the City of St. Louis Department of Health. Thank you for joining us this morning, Dr. Echols.
My pleasure, thank you.
Also joining us is Dr. Alex Garza, the Chief Medical Officer for the SSM Health, and the Incident Commander for the St. Louis Metropolitan Pandemic Task Force, which is a regional task force organized by the hospitals in order to coordinate this response. Welcome, Dr. Garza.
Good morning.
Good morning. Also joining us, thank you so much for joining us after what sounds like an eventful morning, Dr. Laurie, a trauma surgeon at Barnes-Jewish Hospital and associate professor at Washington University St. Louis School of Medicine. Welcome this morning.
Thank you. Appreciate the chance to join.
So what I'd like to start out with is I am going to show just a few statistics so that we can get those kind of on the table and in our head and try to move past them a little bit into what it is that we want to talk about, which are the real pathways. So this is some of the most recent national data that I could find through April 27th, 2020. This is from the American Public Media Research Lab. And this shows the gap between the percentage of each state's and the District of Columbia's population that is African American, and the percentage of deaths in that state or District of Columbia that are African American. So the gap that you're seeing, the longer the line, means that there is a larger gap between the amount of African Americans in that state and the amount of deaths in the African American community. So it shows the disparate outcomes. Missouri ranks 6th right now, where 11% of our population is African American, but 39% of the deaths from this disease have been African American thus far. So this is not just a St. Louis problem, but we've got a particularly heavy case of it here in St. Louis. Everything kind of flows to the middle. St. Louis has all of the nation's problems boiled down to a nice concentrated stew. That's why I think this is a good place to address these issues. So what I would like to open up a question to our panelists with is, when we look at these statistics, I have a member of my own family who has a medical background, is 83 years old, and I showed these statistics to, and her response was that she believed that African Americans were somehow biologically more vulnerable to the disease. And when you look at these numbers, this might be people's first initial reaction. That's what the numbers we're talking about. Clearly, there's no biological facts underlying this, although there's a lot we don't know about the disease. What are those underlying factors? So if you had that family member of mine in front of you, I'm going to put this to the panel. What is the story that you would tell for why these gaps exist? And we'll start with Dr. Garza.
Yeah, no, that's a great question, but it's there's this great quote from President Obama when he was talking about other disasters, and it was, when disasters strike, it tears the curtain away from the festering problems that lie beneath. And I really believe that that is what COVID is showing us, as it does with a lot of other disasters. And those festering problems are issues with inequality in society. And so we all know that African Americans and people with low socioeconomic means suffer disproportionately from healthcare issues. So whether that is diabetes, hypertension, heart disease, stroke, all of these things, I would be surprised if we didn't put up similar statistics showing those diseases that the spread would probably mirror what you're seeing right now. And so I have seen nothing, nor would I expect to see nothing to say that this is related to biology. I believe it's more related to the inequities within the community. And so when you have people that are, and then if you take that natural sort of extension of that, these are things that then make you more susceptible to not just COVID, but to many other disease processes as well. So if you have condensed urban living with multiple families, if you have coexisting disease, whether that's diabetes or hypertension, things like that, and if you have limited access to healthcare, healthy foods, all of these things, education, and then I think one thing that isn't also as highlighted as it needs to be is a lot of these communities that are that are affected by this are the people that are also have some of the higher risk because of what they have to do for their daily living. So, for instance, a lot of them are those essential employees that have to use public transit, which again increases your probability of exposure. That work in some of these businesses, whether it's high customer contact, whether it's working in grocery stores or some other things that again increase your probability for exposure to the virus. And so, if you combine all of those things, it makes it more understandable why these disparities are the way that they are. And so I would, refute your family member. I'm sure they're a nice person, but that much of the risk doesn't lie in the biological side. It is in all of those other issues that, frankly, we struggle with as a society and as a community, rather than on purely a biological basis. And I'm sorry, that was a rather lengthy answer to a simple question, but
That's quite all right. It's a complex subject.
yeah.
So I would put it to Dr. Echols, the same question. If you could kind of make that case for somebody and try to get them to see past that initial assumption and understand the kind of systemic and deeper issues at work here, how might you do that?
So I agree with a lot of what Dr. Garza said. So the statistics and the inequities that we see related to COVID-19 are not new. When you look at other chronic diseases and issues that impact health outcomes in minority and economically disenfranchised communities, the picture for those conditions look very similar. And so really the question is, what's the root cause of this picture that we're seeing? And so in order to really understand the root cause of these inequities and disparities, we really have to understand the evolution of the health system and how certain populations have been ostracized or treated as others, while some other populations have actually benefited. And so this is a manifestation of that. And so we have communities where resources have been pooled, and you have individuals that have lower wage salaries, lack of access to quality health care. And I say access to quality health care because accessing care is only one piece of the puzzle. So, and I can talk about some of my personal experiences where even as an educated African-American male, I've been refused standards of care. And so until people have learned of my position or my title. And so that's really concerning. So if I'm experiencing that, I know that individuals who are may have less education and lower salary wages, they're experiencing this on a much greater scale, and a lot of them don't know how to advocate for themselves when they seek medical care. And so it's a very complex issue. And so again, I think this is just it's not biologically based, but it's really systemic based. And so we have to understand the root cause within the system, but then be comfortable enough to call it what it is. In the public health realm, we call it social determinants of health. We also call it systemic and structural racism. And so we have to really own that, and then actually identify what strategic ways that we can actually address that in a sustainable and effective way.
Okay. Thank you. Dr. Punch, I'm going to throw that same question right over to you.
Thank you. So there are two statistics that have really helped me understand. I completely agree with everything that's already been said, but these two statistics really change everything in my mind. First is the fact that in New York City, the Latinx population is actually the population that's been the most severely impacted, representing 34% of the deaths from COVID, and representing about 29% of the population. Whereas the African American community in New York City represents 28% of the deaths. So, and 24% of the population. I think that's really, really telling. We're an ethnic group. So not even a racial categorization, which is also, we know, a social construct, has had a disparate experience in the epicenter for COVID in the United States. The other statistic is that second to New York or third to New York and New Jersey, the Navajo Nation is experiencing the highest incidence of COVID overall in the country. So those two statistics just tell me, well, wait a minute, this has absolutely nothing to do about race and everything to do with the other factors like proximity, access, social structures, and baseline pre-existing health concerns. So yeah, 100% echo what everyone is saying. This has absolutely nothing to do with a race or a biological phenomena that might somehow be related to that social construct.
So what we're talking about here is the result of a couple of centuries of systemic institutional bias that has cut off healthcare access, resources, community resources, social access to communities of color across the nation. We're saying that the idea here is this is a systemic issue that needs to be looked at through the lens of systemic racism, as opposed to the lens of biology. Am I kind of summarizing that right?
Absolutely.
Okay. And I think that's that first core point I really wanted to get established. So when we think about that, what I would love to dig into a little deeper is for folks that haven't yet had the time or the opportunity, or perhaps the will to work their way into what systemic racism is and how it affects people. I'd love to hear a few stories, kind of what are patient experiences. Let's say a patient coming from a community of color, under-resourced community with diabetes, as opposed to somebody coming from a highly resourced community, maybe predominantly white community with diabetes. Those kind of stories that show what that actual mechanism is would be great. And maybe Dr. Echols, if I can start with you, you already volunteered to tell a story about yourself and your own experience, if you'd be willing to do that.
Absolutely. So part of what we recommend as part of annual screenings are just annual HIV screenings. And so when I was in Illinois as the Director of Communicable Disease Control Services, I selected a new PCP, went in to check in and have my annual physical done. And as part of my physical, I recognized that they didn't put in, recommend for me to get HIV screening. I said, I want an HIV screening. He said, no, well, you don't need it. And I said, why don't I need it? Like as a patient and as a public health professional, I understand the need for having this really critical screening. And so we went back and forth, and not until the individual knew that I was the director of communicable disease for the state of Illinois, that they offered to actually provide for me the test. So that's one example. Example number two is my father. So my father, 65-year-old male, African-American male with a history of diabetes as well as heart disease, presented to his medical provider with chest pain, but this was a different type of chest pain according to him. And so he went in, was dismissed or was told to just take Advil and you'll be okay. The pain didn't go away. Went back again, went to another physician. Oh, it's just take Advil with Tylenol and it'll go away. Finally went to a physician that actually listened to him and heard him, was immediately taken to the cardiac suite because he was having a myocardial infarction or heart attack. Had arterial blockage of greater than 90%. And so, again, the delay in getting him access to proper treatment was because of he was treated differently. If you look at the statistics as it relates to individuals who present with chest pain and are linked to proper cardiac treatment or heart treatment, whites are more likely to get the more invasive or appropriate care versus African Americans. And so that was my father's real experience. And luckily he was able to advocate for himself and sought multiple medical opinions before, but however, that was at least a week-long wait before he was actually linked to proper care. And so he could have easily been another statistic that had passed because of complications with heart disease, but it was the root cause of that was not only dietary issues, but also lack of physicians' ability to treat him properly because of the color of his skin.
Okay, thank you very much for sharing that. And those are stories that I've heard many before, and we always hate to kind of retreat into statistics, but it is true that those stories aren't just about individuals. It's statistically proven that African Americans presenting with certain kinds of symptoms get different treatment. So we see examples there. Thank you for that. Dr. Punch, if I can ask you, you're in that surgery room, you're in the hospital on a regular basis. Can you tell us a little bit about what those differential experiences look like? And don't forget your
Yeah, sorry about that. So one of the first vulnerabilities or breakpoints that I think occurred when we're thinking about COVID was the way in which, when we were first thinking about who to test, and this is nationwide, we were focusing on international travel and didn't have a focus on the potential for community spread, nor did we, I think we now know, have a real handle on true symptoms of COVID. So I think in real time, have seen stories of people presenting, seeking care, having symptoms that maybe didn't quite fit the boat, not having those classic, this is early on, not having that classic contact with international travel, really having a story that was now, in retrospect, we would have gotten someone in for testing and even thought about admitting them, but early on wasn't really the focus. So that's a structural issue that made it such that there was a slower uptick in recognizing community spread that was happening when community spread was probably happening faster in populations and communities that had segregated poverty and general less access to good health. So I think that's one example. I'm going to tell you, this is the flip side of it, which is the ways in which folks who do not have historic trust in the healthcare system have had a hard time jumping at all the recommendations, as confusing as they have been, right? Wear a mask, don't wear a mask. Stay home, don't stay home. You can work, you can't work. You're okay, you're not okay. Like, if you're already not so sure the system's really for you, and then everybody's saying all this crazy stuff, you're like, these people don't know what they're doing. And then you take it into your own hands, not unreasonably so, right? And so where I see that even happening inside the hospital is families having a really hard time understanding the recommendations the medical team is giving, because they're like, are you really trying to do what's right for my loved one? Or are you not? And I understand that. And also, even people having trauma responses to all the invasive care that's required for COVID. So you tell somebody, I'm really worried about your oxygen, you need a breathing tube. They're like, you're not putting that tube in me. You're just trying to kill me. What is that? That's a trauma response. That's, my life is threatened. I am scared. I'm going to fight, flight, or freeze in this moment because that's what my brain is telling me to do because I'm not safe. And those trauma responses we know are going to be richer, heavier, and more dense in communities with higher prior exposure to trauma. So you've got both a system that didn't quickly adapt to the sensitivity and nuance of community spread in disadvantaged communities. And then once people present for care, you have a group of people who rightfully so are not so sure what's up. And I think that I have unfortunately seen numerous stories of people repeatedly reporting for care and then leaving against medical advice and stuff like that because they just don't feel safe. That's the heartbreaking part, and that's the part as a physician I've really tried to be present to and recognize rather than admonish. Be like, I know this is scary and I know this is hard and I feel you and I hear you, and we need to try to find a way to trust these recommendations and the team that's taking care of you really does have your best interest at heart. Those messages are really hard to be consistent with in real time in a hospital setting or a healthcare setting, when other messages people have gotten, people know have not necessarily been with their best interests at heart. So it's that confusion adds fire to the mistrust that's already there.
Wow. Yeah, that secondary effect of these decades and centuries of systemic racism means that they're unwilling to come to the table. Why should they trust? I think that's a really, really important point. Thank you, Dr. Punch. Dr. Garza, I know also you, with your background in the armed services, and you've dealt with crises in lots of different ways. What is it that brings people to the table in a crisis differentially?
Yeah, that's a good question. So, let me maybe paint a picture on how this compares to almost like a war, and maybe that would be helpful. So early on in the COVID, and I'm just talking about the experiences within SSM, it is incredibly, it's astounding how much bureaucracy gets cut through when you have a common enemy, right? So if it's COVID, then it's like all bets are off, whatever you need, so I was the incident commander for SSM, and it's like, I need this to happen, set up our incident command, get the computers set up, I need people, I need folks working on this, that, and the other thing. And so in some ways that was, in many ways that was very inspiring to see that everybody could rally around a common cause, right? And I believe that we had that in the community as well. And so you saw with our pandemic task force that we were able to bring together the different healthcare systems as well, because we recognized that we had, quote unquote, a common enemy, which was the virus. And so the only way that we were going to be able to survive this, or at minimum work the most effectively, was going to be together, not apart. And then trying to bring the different communities together as well. And when I'm talking about communities, I'm talking about like the public health communities, things like that. And I think they've done a remarkable job as well in coming together and working together for a common good. So that takes you through a good part of this campaign that we're on with the pandemic, but like any military campaign, it goes through different phases, right? And so we sort of had this preparatory phase where we were doing all of these things to prepare for what the cases were going to be coming at us, right? And so we ramped up the hospital capacity, testing, how many ventilators do we have, all of those sorts of things. And then we dealt with the surge of patients, and we're still, sort of at that top end of the curve right now. And so it's plateauing a little bit, but we're still there. But now we've sort of entered into this new phase, which I would refer to as stability and recovery operations, which is, that's what I did in Iraq, was stability operations. And that gets a little bit more tricky because now you have multiple competing interests, right, that want to do, there's pressures on multiple different planes. And so you have to be able to understand where people are coming from. What is their lens? What motivates them? What do they want to see come out of this? And so that could be anywhere from the politicals. The politicals got tremendous pressure on them, right, to reopen economies, to get back to normal, and to protect the public. And so, and a lot of times those are competing interests. Fred, I'm sure, can detail to you, the pressures that he's under as a public health official in the city. And then you have the business community as well, and they have their lens that they view it through, and what motivates them, and what do they want to get to. So it's trying to understand where everybody is coming from, what motivates them, what their goals are, all of those things, and trying to find that common ground to say, okay, this is where we can all work together to achieve a common outcome. And it's by no means easy, and that's human nature. But you can't. The things that I've learned in operating in politics and in war theaters is you can't dismiss people's views as because they don't fit yours, right? You have to understand them, and you have to see how can I incorporate those into what everybody wants, so that you can reach that common goal. I mean, too often people are very dismissive if they don't agree with somebody's point of view, but to them, it's a very legitimate point of view. And so you have to understand that.
I appreciate especially that last point about working your way into someone else's point of view. When we talk about trust, for instance, when we talk about trauma, reminds me, I have had doctors at a local hospital tell me that they were taking an elderly African-American woman downstairs to get an x-ray, and she started struggling and screaming because it was in her living memory that African-Americans who got taken downstairs to in that hospital were not getting treatment. Mm-hmm. They were being experimented upon. Mm-hmm. This was not folklore, right? This was in her living memory. We can look back at the very end of middle end of the 20th century, the death of City Hospital 1, City Hospital number 2, and of course, one of the premier African-American hospitals in the entire nation. So when all of that comes together to convince a community not to trust systems that they now have to trust in order to move past this, that is a massive, massive hurdle we face. So I just want to say to our participants, go ahead and think about some questions that you would like to put to our panelists. You can add that. I'm going to stop sharing this panel. You can add those questions to the Q&A that's at the bottom of your screen. And we will be getting to those questions from the audience in just a moment. I want to go back one more time and ask each of you has a relatively unique perspective. Dr. Echols, both in Illinois and Missouri, you've really been on the kind of systems implementation side of public health. Dr. Garza from the battlefield, and Dr. Echols, I know you've had armed service experience as well. And Dr. Garza at the national level, but not in public health directly, in Homeland Security, which is a very interesting cross point here as well. And Dr. Punch, you're coming at this from a trauma surgeon perspective who's taken that perspective on trauma out of the operating room and out into the community. So from each of those perspectives, maybe starting with you, Dr. Garza, if you could, when we think about this from that national perspective, and we look at these disparities, what is it that we need to be thinking about? We've kind of established what it is that's going wrong. Where can we start to kind of get us moving in the right direction? What are those first things we need to start thinking about? Policy changes, things like that, in order to preferably not have this kind of disparate outcome for the future. I'm not talking about our response to COVID necessarily, but how do we address these underlying issues?
Yeah, that's a complicated answer, but I'll give it a try here. So
Complicated questions seem to be
yeah. There's no one simple answer to that, and so let me talk a little bit broader about this, because I don't think there's any one single policy change that is going to lead to a miracle happening, right? It's the arc bends slowly, right? But there's if you think back to what makes a person so fragile during this time of a pandemic, and we've mentioned all of those things. It's the social inequity, it's economic inequity, it's lack of access to healthcare, all of those different things. And so one of the things that we do, when you're talking about patient safety, is you ask the 5 whys, right? So why is that? And then if you start tracing it back, it gets back to we do have such a huge disparity within our country, right? And so you say, then why is that? And it's things because of racism, because of economic policies that do not benefit the majority of the people, that really favor people that have more access to resources. It's all of those things. And so when people ask me, like, what could we have done differently to prevent the pandemic from being so bad? It's like, well, we could have better income equality, right? We could have better housing. We could have better healthcare, because all those things build resilient communities, right? So there's a reason why, getting back to your very first question, there's a reason why things like this disproportionately affect some communities and not others. And it's not fundamentally because of, as you said, it's biological. So it is more about the structure and the environment that is around an individual. So I'll give you a statistic here. Only about 10 to 15% of what healthcare does impacts the health of an individual. The majority of it are other things like environment, genetics, all of that stuff impacts the health of an individual. In healthcare, we deal with the product of all of those things. So if people don't have regular access to healthcare, live in substandard housing, don't have a livable wage, all of those things impact the health of the individual, and then they show up on our doorstep with all of those things that have impacted their lives. And then, in the way that people typically think about it is, well, if we just had a pill to fix hypertension, well, okay, we can do that, right? But the goal is not to have hypertension in the first place, right? So you have to think far upstream. So from a sort of societal, governmental, whatever you want to call it, policy picture, it has to bends toward equality and towards social and economic equality. And those things are hard because that takes time and it takes continued deliberate effort, and you're always underneath a pressure from other groups that have a very different view on how policy should work, whether that's tax law or anything else. But it all contributes, it all contributes to what we're seeing now.
Dr. Echols, I saw you nodding your head there when Dr. Garza was talking about pressure. Do you want to talk about that?
Well, there's always pressure, whether it's we're in the middle of a pandemic or if it's, what we consider to be the status quo or normalcy. And so the pressure is always there, but the our true intent has to remain unchanged, regardless of the circumstance. And so keeping our approaches focused on health and racial equity has to be at the forefront. This can't be something that we only focus on during these special times. We have to focus on this every single day, especially our most vulnerable populations. We have, more than 25% of the residents in the city of St. Louis live at or below 100% of the federal poverty level. And so that's alarming. So what are we doing to empower these communities and these individuals to a point where they can obtain self-sufficiency? That has to be our focus. And so in order for us to do that, we have to be true learners of the system. And so I've really charged my staff with learning the system, learning how the system works, learning how it has the changes within the system have really focused on pushing certain communities or certain groups to the edge of society versus really welcoming them and providing them with equitable access, equitable quality of resources, and equitable economic opportunities. Until we truly learn how the system operates and how it functions, oftentimes what happens is, we'll get into positions and we'll end up perpetuating the same issues that we're saying we're trying to address, and that's not okay. So really becoming true learners of the system and learning how it actually functions and using that knowledge to actually change the system. It's not going to happen overnight, but there are some little things that we can do day in and day out that can help tease away at some of the challenges and some of the issues that have come to the forefront and are manifesting themselves after centuries of systemic and structural processes. Policy is also important. But we also have to make sure we're looking at policy development through a health and racial equity lens. Otherwise, again, we'll continue to perpetuate those issues that we say we're trying to address. And I think overall, even when we learn the system and we develop these initiatives and so forth, we have to make sure that the community is engaged and the community is at the center. And what does that mean for us? That means giving them a platform, not only to share the information, but giving them a platform where they can be heard. I think the approach for government has been that we need to save these communities. Like, no, we don't need to save them, we need to hear them. We need to hear them, and then not only hear them, but also use their input to develop new programs, new initiatives, so that we can truly meet their needs. Otherwise, we're just giving them what we think they need. And oftentimes there's a mismatch between, our interpretation and their interpretation or their experience. And so being in tune with their experience requires purposeful and intentional engagement. And that can't be done just during certain time periods. It has to be done every single day. And so that's a priority for the health department. And some of the things that we're starting to do now during this COVID-19 situation we're working to build a foundation for that. And so working with groups that we haven't really partnered with before, who have trust of the community. And so, one of the things that we've recognized is that we can't always be the face of a particular program or project because, as Dr. Punch and Dr. Garza mentioned, they don't trust government. And so, but there are great resources available for them. And so we can work with a partner that they trust to at least get them access to the information. That is a critical step because what we can't afford to see year in and year out is the same statistics. Something has to change. And that the first step for us is making sure we acknowledge what we do and how we're impacting the community and make the adjustments that we need to make and hold ourselves accountable. Oftentimes we rely on the community to make all these changes, but we have to be accountable for our role in creating some of the situations and circumstances that are coming to the forefront. So holding ourselves accountable by establishing metrics and using evidence-informed approaches is really important. And so the city of St. Louis really takes this to heart. This isn't something that we expect to change overnight, but we are working to strategically and intentionally engage the community so that we can develop long-term and sustainable solutions to these issues.
Thank you. And I really appreciate that point about engaging and listening to the community. And I'm going to give Dr. Punch the opportunity to pick up on that. And then we're going to get to, we don't have that much time left, then we're going to get to some audience questions. Dr. Punch, you have kind of made it part of your whole model of how you are a trauma surgeon to be out in the community and working with the community. Can you talk about the importance of that and some of the experiences that you've had there and how that might translate here to the COVID crisis?
Well, I'm gonna answer your question, but really just add to what I'm hearing, which is watching our region respond to COVID from individual folks that I've talked to in community, small organizations, large organizations, some of the largest organizations in the region in terms of employment power. It's been fascinating to watch the agility or lack of agility in responding to what the community is asking for. And I have to say that the institutions, organizations, and people, regardless of their personal identity, who have done the work to understand racism, those who have done anti-bias, anti-racist work, people who recognize the culture of white supremacy and the ways in which it drives all those no answers, all the reasons why we can't do what we need to do so that an equitable outcome is available to all. If you haven't not done that work, it's been amazing to watch institutions and people who haven't done that work try to bend and respond to COVID versus organizations, people, institutions that have. And the answer, just like Dr. Garza said, it's incredible what you can do when you have a common enemy. The answers that I see us creating now that are in response to this unquestionable need have really, from each mouth that I've heard, been completely, like the degree to which they are impactful, in my humble opinion, is the degree to which they are free from the restrictions of maintaining the financial and economic realities of slavery. I mean, literally. And so I think, I see a lot of questions about policy. I don't think you can do the policy work until you do the heart work. I don't think you can come up with the solution. I don't think you can hear until your organization, your group of people, and you yourself, regardless of who you are, this has nothing to do with you. I mean, everybody has to learn this. We don't learn this in history class, right? This is something that's it's relatively new to understand. And so we all have to learn it so that we can be nimble and responsive to the needs as they exist.
Wow. I especially appreciate that point about being able to hear, right? If you haven't done the prep work, you're not going to be able to hear. I've seen the disparate outcomes referenced in, well, that's just the same old health problems. So yeah, we're ignoring the herd of elephants in the room because they've been standing there the entire time, right? Yeah. So thank you for that. I'm going to go ahead and jump in on some questions from the audience because we have some really good questions coming. And this is kind of a practical one that I think is interesting because we mentioned that a lot of these communities are more vulnerable because they are at the front line of essential services, right? They're filling those jobs that we need right now in terms of the food lines and all of those things that are keeping food on our table and keeping things flowing. So here's a question for those of us leading essential services on behalf of our clients or patients. How do you want us to frame the flattening and dropping out of the crisis for our employees? How do you advise we talk about balancing or blending work with self-care as we look into the summer and a future uptick for the fall and winter? So if we're talking about somebody that's managing employees that are in that essential space, that are looking at, do I want to come in and expose myself for that $12, $13, $14, $15 an hour if they're lucky? Do you have any advice? Do we have anything that they can, a way for them to frame and understand the current crisis and the risks for their employees? Who wants to grab that one?
Yes, I'll start. So one of the things that the health department has recommended is for all businesses that are deemed to be essential that they provide PPE for their staff. And so that reduces or minimizes their potential for being exposed to not only COVID-19, but other respiratory illnesses. But also it's important not only that they provide those resources, but also that they teach them how to properly wear them. And so make sure they have proper instruction so that they'll be wearing them appropriately. In addition to that, reviewing their HR policies. So oftentimes, individuals can be penalized if they're off for a period of time. And so they can really make their HR policies more flexible so that the workers don't deem to be penalized for taking time off because of communicable disease or infectious disease exposure. That's really a few steps that organizations can take.
That's great. I've got another really good question here. How can a white behavioral health provider be sensitive to the needs of patients of color? Behavioral health is something we haven't even touched on yet, except to mention trauma. How would you answer that?
I can try to answer. Again, it's really that what I just said, that I think having a trauma-informed approach is like universal precaution, right? You have to come into a space recognizing that just having the person, whether it's telehealth or physical presence, just making the steps to get to that place where someone is seeking care is trauma. And to approach people with just an immense level of awareness of the how much COVID is impacting that trauma. The other thing is, I think, approaching people with a posture of curiosity. It transcends race and identity in every way. Like, no assumptions, just really allowing people. I have seen people of all sorts of identities become immensely therapeutic to people because they simply were able to move into the space with humility and just gentleness, just to kind of be like, tell me where you are. I think there's an assumption that you somehow have to share an experience with somebody to be able to work them through it. And I think more your skills as a trauma-informed facilitator and somebody who understands trauma is way more important right now. And I guess the last thing I would say is the chasm of experience that exists for those of a lower socioeconomic status, or those who are in segregated, concentrated areas of poverty. The chasm of experience and the collective shared burden. Like, in other words, anybody who's presenting to you who's coming from one of these heavily impacted zip codes is not just walking in as an individual, right? They're bringing with them an entire community of folks who are burdened. And the chasm of experience that might exist between you as a professional, not making any assumptions about who the person is, and the person you're talking to is so vast. It's so beyond vast. I think really, I think you have to start by really understanding that. Like, when I'm, just the most basic things that people are dealing with right now, and the way that it's not just them, it's everyone around them. That's really caused me to take a very, just again, gentle, open, curious, and present tone with everybody I'm interacting with, because it's for me, I liken it to a continuous mass shooting, and everyone is feeling the impact right now. Something super important to keep in mind.
Yeah, and if I could add something to what you just said there, Laurie, and I think that is, and I think you touched on this with being humble. If you can, when you're, so I'm an emergency physician, and I worked in inner city hospitals in Kansas City, Albuquerque, and Washington, D.C. And I think, when you are taking care of patients, and this is one thing I used to tell the residents is, like, most people aren't here because they want to be at the emergency department, right? They're usually, there's a reason why they're here, and it's up to us to find out why they're here. And it may not be a medical issue. It could be a social issue. It could be something else. So that's one thing. And the other piece, I think, is treating everybody with respect. When you're taking care of, people that are homeless or have or come from difficult walks of life, they're used to not having respect. And so if you can show them that modicum of respect, which you should be doing anyway as a healthcare provider, that goes a long way. And then the third thing is and I think you touched on this as well, Laurie, is you have to be their advocate. So even if things don't make sense medically, or if there's reasons for not doing certain things for patients from a scientific point of view, you still have to be that advocate for the patient and make sure that their interests come first, rather than expediency or any of a number of other things. And so, and that's important to teach our ongoing cadre of healthcare providers. Is these are just as important skills to learn as knowing how to diagnose a diastolic murmur. In fact, they're probably even more important. But having that level of respect and advocacy for people is very important.
I love those concepts that we brought up in response to this question. Respect, humility, gentleness, curiosity, advocacy. I just wanted to repeat those because those seemed like a really good recipe is generally for a responsive and effective healthcare system. We've got a few more minutes. There's two questions here that I want to kind of roll into one a little bit. Given the obvious nature of the disparities, are there some ways that we could put our foot on the scale in the other direction? And I have two specific questions here. Number one, could we not just make testing available, but actually make these vulnerable communities preferred communities for testing, preferred communities for free testing? So can we kind of put the gas, hit the gas going the other direction that way? And the second question that's a little further down the line, when at some point, hopefully, we talk about having what's the word I'm looking for the virus, inoculation for the virus.
Vaccine.
That's it. Thank you. A vaccine for the virus. Can we look at preferentially treating those communities that are disparately impacted? Has there been any talk of that? Have you heard that? Is there a political possibility of that?
So I think I think the short answer is yes. But when you're thinking about, so we have, as everybody knows, limited capacity for testing. Given where we are in the pandemic right now, and we're getting better at this, we can understand what segments of the community are most at risk, right? So it's nursing homes, North County, North City, communal living, places like that. And so if you're thinking about, I have this limited capacity for testing, now where should I concentrate that? So again, I'll use some like wartime analogy. If you know the enemy is in a certain segment of, your area of operations, that's where you're going to concentrate, your firepower is there, right? And the same holds true, I believe, with dealing with the pandemic. This is where we need to focus testing, contact tracing, wraparound services, all of those things, because it's, first of all, it's the right thing to do, but it benefits everybody, right? It doesn't just benefit that community, it benefits everybody. And then the second piece is with your question with vaccine. If you're thinking about vaccine, where is it most valuable to use vaccine? And of course, it's at the highest risk populations. We do this with flu vaccine, we do it with other vaccines, right? And so that would be the same consideration should go into that. Now, with that being said, and I'm sure Laurie and Fred would back me up on this, is it has to have the community face on it as well. So as people have expressed, there's a lot of distrust in the healthcare system. And so if you're going into a community to deliver vaccine, that has to be delivered through that community voice, through that community lens. Otherwise, there's a healthy degree of distrust on why are you giving it to me and not giving it to other people, right? So it's not as simple as going in and doing vaccination. It has to be the whole package.
Okay. That makes sense.
So I think as it relates to testing, so testing, making it widely available to everyone, regardless of symptom profile and so forth, is really important. And so there are some measures or efforts that are being made to make that happen, hopefully within the next 2 weeks. But that's absolutely necessary. And we're also looking at which populations need access to. We were standing up the mobile testing centers. One of the things that we were looking at was the data. Sorry, my light went out. We were looking at the data, and the data was really driving our decision as it relates to where those sites should be placed. As we move forward through the situation, we're identifying other areas that are that don't have testing sites, and we're working with other agencies to hopefully get those sites up and running within the next couple of weeks as well. As it relates to pharmaceutical interventions, particularly vaccines, that's a really tough pill to swallow for minority communities and for a variety of reasons. So when you first mentioned vaccine and preferred treatment for minority communities, the first thing that comes to mind is the Tuskegee experiment, because that's how it was proposed back in the day. And so, but making sure that there's evidence for the vaccine before it actually goes out, and you have someone that the community actually trusts to advocate on behalf of this particular recommendation or requirement, so that the community can receive it well. I mean, singling out of the community is one thing, but when that community has a history of being targeted and ostracized from health systems, you have to really do your due diligence and learn what impact that has had on that community, and that'll help hopefully pave the way forward for you.
Can I just ask one follow-up question, Dr. Echols? I know this has always been your focus, but as nationally the disparate outcomes for COVID-19 become more prevalent, is it becoming, for lack of a better term, politically easier to make sure that those resources are going to the right places, including the resources to make sure that that community engagement piece happens?
Right, and so there's a politics. Everything can be politicized, right? But as I mentioned before, I have to remain true to my purpose in this space. And so, regardless of what's happening around me, or regardless of what other individuals may deem to be appropriate, I have to make sure I'm doing what's in the best interest of the community. And implementing data-driven initiatives and programs is a part of that.
Okay, thank you. I'm going to go ahead and give you all a chance if you have any closing thoughts. There's so much in my notes we didn't even get to. There's so much information here, so much for people to know, but anything that's really been in your mind that you'd like to add here to the end before we wrap it up?
I'll just end with what I started with, which, when disaster strikes, it tears the curtain away from the festering problems that have always been there. And I think, if we, I'm hopeful that coming out of this, we'll start addressing some of those festering problems. And the best way to prepare for the next pandemic is to fix those underlying structural issues. As we can do all the testing and vaccine development that we want, but at the end of the day, if we have a healthy, vibrant, equitable community, that's going to make the difference.
I want to say a right here, right now, harm reduction model that we have got to push out and have in place by May 15th, if that's when we start relaxing the shelter in place order, is widespread access to PPE. And as Dr. Echols said, the education to know how to interact with it constructively. I see a lot of people with masks around their necks. I don't know why people are sagging. That ain't the way to wear a mask. And it's huge though, right? Because it's not everything, but it's a major mechanism. And I know Prepare STL, with collaboration with everybody here, is working as hard as they can to get a widespread PPE access for the community over the next 3 weeks. I think it's stupid important. And if people are looking for a right here, right now kind of thing, helping people in the communities they serve understand PPE, understand the need to have ongoing physical distancing. You can still be 6 feet apart even when we're not sheltering at home, and understanding the ways to effectively interact with PPE. That we are in desperate need as a whole region for people to understand that. And if there are efforts that can happen right here, right now, I personally think that's one of the most important.
Absolutely. I think everyone has spoken to the complexity of the root causes of the disparities that we're seeing in our community. And what we have to do is utilize this opportunity to start addressing those issues in an effective way, and using this as a platform to be better and greater moving forward. And the health department wants to be at the forefront of that. We need to be at the forefront of that because the community needs an agency that they can trust. And our goal is to make sure that we're engaging them consistently so that that trust can be obtained over time. In the meantime, we will be working closely with all of our partners, Dr. Punch, Dr. Garza, great partners across the health system. But it's also important for us to engage those non-traditional partners who haven't been at the table, because there's work for them to do as well. This requires a system lift. In order for that to happen, we need to make sure everyone plays their part, everyone knows their part, but then plays their part consistently across the board. And so we're looking forward to what's going to come over the next coming months. But we're also excited about what happens after COVID-19, because again, we're really purposeful about how we're utilizing this time to set the tone for addressing these systemic and structural issues moving forward. And so we're really excited about that. It's a lot of work, and we also need to have to manage individuals' expectations. So what we're seeing is the manifestations of centuries and centuries of work. And so it's not going to happen overnight. But if we tease away at it consistently, we can make an impact and improve health outcomes in our communities.
I really appreciate, Dr. Echols, that you brought us around to just a moment of optimism here at the end. Because I agree that at the end of this, we should not be doing a return to normal, right? Because normal doesn't work for a lot of people. And what we've actually seen here is the possibility of real coordination, the possibility of real resource sharing, the possibility of real collaboration and information sharing. And I think that the possible tiny little silver lining is if we can take that and move it forward and address these structural long-term issues with the same sense of urgency. So I would really want to thank you all. I know you all are on the front lines of all of this and took time out to be with us today. So thank you very much for that. Thanks to everyone who attended. And I look forward to talking again. Have a good rest of your day. Thanks, everybody.
Thank you.
Thank you.